Well, hi again, everyone. Happy Friday. Hope you're staying warm. It is so good to have you with us for the January edition of the Meeting the Moment webinar from the Saul Zaentz Charitable Foundation. My name is Dan Worry. I am an author and an educator, and so pleased to serve as a strategic advisor to the Zaentz Foundation and as the host of this series. As you know from the Meeting the Moment name, we are always on the lookout for topics that are timely and resonant, and boy, really couldn't pick a better example of that than our topic today, which is the American healthcare debate. It is a topic that is on the mind of millions this month in particular, as the Affordable Care Act's enhanced subsidies, which have been in place for several years now, have recently expired. That will equate to higher premiums for many in the country. That said, for those of us who are not healthcare policy experts, the debate over the healthcare system can seem at times almost inaccessible. It's very complex. It is a difficult debate to follow in some cases, much less participate in, which is why we have brought together three of the topic's leading authorities today to help us kind of cut through the jargon and complexity. I was joking with the panel earlier. There's a famous forum on Reddit called Explain It Like I'm Five. I don't know that we need to go back quite that far, but we're definitely hoping to sort of cut through the jargon and demystify some of these complicated issues today. I am delighted to be joined by Dr. Elizabeth Fowler, who is a distinguished scholar at the Bloomberg School of Public Health at Johns Hopkins University, Rachel Nuzum, who is Senior Vice President for Policy at the Commonwealth Fund, and Chris Jennings, founder and president of Jennings Policy Strategies. We're so glad to have all three of you with us today. Before we jump in, just one housekeeping note. Later in the hour, we will try to pose some questions that you have on your minds. If you've got a question throughout the hour, if you would put that in the Zoom Q&A function at the bottom of your screen, as opposed to the chat, which we can kind of move quickly. That way, we'll have all the questions in one place, and hopefully don't lose track of any. So, with that, I want to kick off our conversation. Liz, I'd love to start with you. You were instrumental in actually writing the Affordable Care Act, which is the foundation of our current system. For the average person watching, I very much consider myself in that category, by the way. Can you maybe explain sort of the three legs of the stool regarding how our system works currently, and what was the original goal of the ACA? Where are the big gaps? And then maybe in terms of current events, what is the impact of the expiration of these expanded subsidies that have been in place now for a couple of years?
Sure, Dan, and thanks for having me. I really appreciate it. And I think for anyone who follows our U.S. health system, there's nothing simple about it that would be comprehensible to a 5-year-old. But I'll try my best. So I think, you know, probably about half of our country receives health benefits through an employer, another portion through Medicare or Medicaid or some other means. But put yourself back in 2010. Probably upwards, reaching close to 18% of the population, perhaps more or less, depending on what state you lived in, didn't have coverage. You're not old enough for Medicare. You didn't get health coverage through an employer. You make too much money for Medicaid, or don't meet any of the qualification standards, and sometimes there's a lot of trouble finding insurance. And so what the ACA was aiming to do is really try to find a solution to expand coverage and hopefully reach universal coverage where everyone had some option. And to do that, the ACA had to tackle three problems in this market for these individuals who didn't have employer coverage or qualify for anything else. Try to reform some of the insurance market policies that prevented them from getting coverage. So today we might not remember, but back then, if you had a pre-existing condition, you either couldn't buy coverage or it was very expensive because of underwriting, medical underwriting. This happened to my mother who had a pre-existing condition. She couldn't buy health insurance after they retired. She wasn't eligible for Medicare, didn't have retiree coverage, and really was just kind of out of luck. So first is reforming that insurance market to make sure there's a place for people to go where they can buy coverage. In order to make sure that we had enough people in that what we call a risk pool or buying insurance, we had a requirement that you had to buy coverage. So we wanted everyone to have coverage. So if you didn't have other means of insurance, you purchased it. And then the third, and I think the topic of that will be explored today is making it affordable. So how do you make insurance affordable? And that's ACA. And, we can debate how, whether or not the insurance subsidies work well enough, whether they really made it affordable, but they were only allowed to vary by geography, family size, and age to an extent, and by smoking status. During COVID, when we wanted everyone to make sure they had coverage, we expanded those tax credits to make them even more affordable. And those expanded or enhanced credits were extended in the Inflation Reduction Act, but only temporarily. And that's what expired in December, was that enhanced subsidies. We got our insurance uninsured rate down to 8%, which is the lowest it's been in the country's history, in part because of these enhanced subsidies. And now those have expired, and I think a lot of people are facing increased premiums, trouble finding an affordable option. So let me just add one more point before I turn it back, and I'm apologizing for a long answer. A lot of people say, well, why didn't you just go to some simpler system? Like, that sounds really complicated. Why did the ACA come up with this complicated approach? And I think, if you're someone with employer coverage or you had existing coverage, you didn't want to lose that coverage. I think one of the lessons that we learned from previous attempts, and Chris could probably speak to this more poignantly than anyone else, why didn't, people, when we tried to reform the health system in the past and move to sort of a more comprehensive, like, let's simplify the whole thing and move to like a single payer, for example, or a system that was more comprehensive and coherent, you generate a lot of opposition because those who have something don't want to lose it. And so this built on the existing system, the enhanced subsidies are now going away, and I think we're sort of backsliding a little bit into sort of an arena or an area where people have trouble finding coverage. We're still ahead of where we were in 2010, but combined with some of the policies in the One Big Beautiful Bill that passed in July, which I'm sure we'll get into, we're sort of backsliding a bit from our highlight or our apex of coverage in the country.
Liz, thank you. Rachel, I want to turn to you. The Commonwealth does a lot of research on how the U.S. compares to other wealthy nations. We spend significantly more money on healthcare than many other countries. Yet we often hear that our outcomes are not as good. So, in kind of plain English, what are we paying for? Maybe that other countries aren't, and what's impacting that high cost? Is it administrative waste? Is it something else? What's behind that?
Thanks, Dan. Thanks for having us. So the Commonwealth Fund does international surveys and has been tracking how, what we spend and the outcomes that we get for, over 40 years. And there's a combination of both what we're spending more money on. So things like administrative costs, the part of the healthcare system that is really oftentimes invisible to patients and to their families, but the administrative costs and then therefore the administrative burden that puts on providers, that is an area where the costs in the US kind of far outpace our international peers. There's a lot of, at one point there was a sense that, folks in the US were using services more than in other countries. And in fact, it's not that the utilization is higher, it's that the prices that we're paying for individual services are often out of alignment with what other countries are paying. Our healthcare system does not go through a process like some other countries do where we set a budget. So that is kind of the first step. And so a lot of our programs, Medicare and Medicaid or entitlement programs, they grow as they are needed. The costs kind of adjust to pay based on the need. But the rest of the system is really, being responsive to the services people are getting and to the fact that we do a lot of fee for service, meaning if you go in for an X-ray, the more the providers do for you, the more they're getting paid. And so kind of the way that we're paying, but also the prices that we're paying really set us apart from our international peers. There's also a really important area where we're spending less. And we don't usually hear about this where we're spending less money. We spend less money on primary care than almost all of our international peers. And it is the one place in the US health system where the evidence is really strong that if you spend more money, you actually get better outcomes. And so we're doing two things kind of wrong, if you will. We're overspending in places like administrative services, administrative costs. Our prices are much higher, and we're under investing in those places that have really been proven to show that they can go a long way towards improving those health outcomes that you referenced, as well as kind of meeting everybody's needs. The other big area where a lot of other countries, kind of pull services in and how they define healthcare spending are around things around the social drivers. So housing, transportation, food, those services that are adjacent, oftentimes they're, more integrated into the health system than they are here. And we know from, a lot of work that about 80% of what's contributing to people's health outcomes is not happening in the healthcare system. It's not happening between you and your doctor. It's all of the other kind of, things that are impacting your life. And so those are really kind of the main reasons. There's a lot of variation in how countries structure their healthcare system. But when we look across kind of at the aggregate, it's both how much we're paying, the prices that we're paying, and also where we're not investing that's really setting us apart.
Rachel, thank you. And I know we want to dig in on some of those things a little bit more throughout the hour, but I want to bring Chris into the conversation as well. Chris, Liz sort of referenced it earlier. You've been an important part of this conversation now for many years. You've advised multiple presidents on healthcare policy. When we talk about the healthcare debate in Washington right now, it certainly, along with other topics, can feel very polarized on a partisan sort of basis. But what everyday Americans, I think, mostly are worried about is access and affordability. So from a policy perspective, why is it so difficult to lower costs for the consumer in the system? Are there big headwinds that are stopping the prices from coming down for all of us?
Well, yes, Dan. I mean, one person's perception of overprice is another person's income, you know. And there's a lot of everyone. You ever heard of this thing where people say, tax it, don't tax me, tax the person behind the tree, and there's always a kind of a finger pointing exercise. If you've watched Washington, it is very frustrating. It's not just frustrating in terms of the politics of the day, the ideologies, the left and right, Republican, Democrat, but it's also stakeholders fighting amongst themselves. And in Washington, we call people stakeholders. You know what stakeholders are? They are special interests that we like. And if you're not someone we like, then you suddenly become a special interest. So we have to get through all those code words of who's up and who's down and what people value. My view, a couple things that I think a lot of people don't know, even about our healthcare system. As most of us who are working get our healthcare through our employers, and they think our employers are paying for it, but we subsidize our through the tax code the provision of healthcare. If we didn't subsidize it through the tax code, healthcare would be even more perceived to be much more expensive. And the reason why the marketplace seems very expensive is because we're about to lower the subsidies that we provide people in the so-called Affordable Care Act marketplace. So there's lots of different dynamics that affect affordability. One thing I like to explain to people about cost is that healthcare affordability even has to be defined about what you're talking about. Are you talking about affordability to the government, affordability to the taxpayer, affordability to the person who is just trying to seek health care through their premiums or their out-of-pocket cost? And of course, if I lowered out-of-pocket costs in healthcare, premiums go up unless I subsidize those premiums or unless I find ways to lower prices. And to answer your question directly, some of those basic understandings of, just give me healthcare more affordably. Just stop talking to me like this. Just, I want lower premiums, I want lower out-of-pocket costs, and I want to get care with the people that I want to get care for. And if we as insurers, whether we're public insurers, Medicare for all, or private insurers or whatever, said you can go to anyone you want to, that would cost you more too. And so you have to make some decisions about what kind of benefits you want to cover, what kind of access you want to provide, and are you willing to be disciplined about how you pay for those things? Are you willing to say, no, you can't charge whatever you want. We're going to lower those prices. And I have to say to you, um, it can be done. It really can be done. Um, but those debates affect those stakeholders. They affect special interests, and yes, they affect politics. Democrats tend to care a little bit more about coverage and affordability. Republicans care a lot more about choice and innovation and are willing to pay a little bit more for that. And sometimes you have to kind of say, okay, what is the balance that we want to have to appease things? I think one thing we're going to talk about later, I hope, Dan, is there are actually some places where there's real bipartisan support for healthcare advancements. But in terms of coverage and costs and who pays for it and how much, that's where the rub really comes. And what I'm sort of excited about, as much as people are frustrated about, is I really feel that we're about to have another significant new healthcare debate where people are going to say, I'm sorry, we're paying too much, and we're going to have to do something where we get to Rachel's point. We talk about budgets, or maybe we talk about premium caps, or we maybe talk about payment caps, because in the end of the day, if we try to do much more complicated things, what we're going to find is we're not going to be able to keep up with the system. It will always be too expensive for people to afford. And if it's too expensive for people to afford, we're going to have more and more people who are uninsured and frustrated with our healthcare system. And so I'm sorry I can't tell you. I can tell you the reasons why we've had a hard time getting it done, just as because I've just explained some of them. But um, I think the policymakers right now, we just had a hearing on Liz's old finance committee where the Republicans and Democrats were tripping over themselves saying, we can't just subsidize our way out of healthcare. We have to deal with cost. Both sides were talking about it. So it's opening up the door for a real discussion. And I'll tell you, it's going to be a painful one, but it's going to be something that's long overdue.
Well, let's tease that out a little bit. Liz, Chris is saying it can be done. I was interested too. I mean, I think so useful in your description of kind of the origins of the Affordable Care Act being something of a compromise, right? That it's hard to create something sweeping that might take away what people are already comfortable with. So I thought that maybe it'd be helpful, and this is maybe not a question exclusively for Liz. Would love to have all of you weigh in on, but some of the a couple of alternatives have been pretty widely discussed that I'm not sure that everyone understands really well, including President Trump just here recently in the past couple of weeks outlined at least the very broad strokes of what he's calling the Great Healthcare Plan. Um, for the audience who maybe has heard a little bit about this on the news, are you able to share a little bit of sort of at a high level, what that would entail, how it would be different from the Affordable Care Act that we're operating under currently, and how, if at all, would you envision that it might help to address this affordability question?
Well, first of all, let me say that there isn't a lot of detail. So how it actually works, how much money that he's talking about. So he said, let's give money directly to people, which I think is a nice soundbite and it sounds good. But what does that actually mean? And he's sort of likened this approach to health savings account or flexible spending account that a lot of us may have through an employer, for example, where you set money aside and use it in the future, and perhaps it's in a tax favored account that grows over time because of investments you're able to make to, and then you use those dollars to cover expenses that aren't covered by insurance. So this notion of, you know, giving money directly to the people, I think sounds appealing, but okay, so you get $1,000, $5,000. First of all, there's a lot of, again, we don't have a lot of detail, but those numbers matter a lot. Who gets the money? How it can be spent? What do you spend it on? I think these are really important questions. But I think most importantly, if you're someone with a chronic condition, you have a child with a special health need, you have a diagnosis of cancer, that $5,000, even if it's $10,000, is not going to go very far. It's not going to cover even a trip to the emergency room, if you have none of those things. And maybe it grows over time if you put it into a health savings account and you invest it in some mutual funds. That's going to take a long time before it's ripening to the point where it's going to cover what you think you need. So I mean, I also think trying to implement something like that, as somebody who's worked on drafting legislation and implementing legislation, healthcare legislation, there are a lot of operational details that make a big difference. And if you're worried about fraud and abuse, think about the notion of giving people just money in an account and who gets it again, where the money goes, who administers it, how it's used. I think these are really important operational details that could generate, I mean, it could eclipse any sort of fraud you're thinking exists in the current system. So, I don't mean to be so dismissive, but I just think it is more of a soundbite than it is an actual policy that could be implemented and address the problems that we have at hand today.
And I would
Chris and
just
Rachel, I'd love, yeah, jump in.
Sorry, Dan. I was just gonna, I mean, I agree with everything Chris and Liz said. And even assuming you could operationalize, this plan, which would need several, layers down of detail, you are still not getting at, I think, what all of us were talking about at the beginning, which is, the healthcare costs themselves. You're squeezing a part of the balloon. I think it's a reflection of the fact that a lot of people are frustrated at, their they're watching their premiums go up. They're not able to kind of reliably predict what their healthcare costs will be. And this seems like a bit of an acknowledgement that people are frustrated, but there's little in there that would actually change, the financial incentives for providers, for hospitals, for systems. And that's probably more along the lines of the difficult conversations that Chris was talking about that we need to have if we really want to see meaningful change. That last thing I want to say is, we all want to talk about affordability. We have to remember, Chris's question, affordability to who? One person's savings is another person's economic, reduction. It's a one person's job that may be going away. And so we have to remember, as we're thinking about kind of the broader healthcare conversation, it is a major part of our economic engine. And every tweak or every change that we make has a lot of stakeholders and opinions around it because of how much it is generating for the economy. And so thinking about that, having to take it all into account at the same time, and thinking about, are we taking action that's making meaningful directional change around healthcare costs? Are we kicking the can a little bit further down the road, which tends to be our strategy? It's a lot easier, and invariably makes it more difficult to kind of solve as we go.
Dan, I just say that uh, of course everything Donald Trump does is great, and is going to be phrased as great. But as he said himself, who knew healthcare was such a complicated thing? You remember how he said that, and it's just not his forte to stay focused on a big thoughtful policy. He's mostly trying to convey the concept of let's give people accounts. And one thing to remember about that is that actually accounts can work for some people, particularly if it's for elective procedures in healthcare. Like if you don't really need it or you may want it, then you can actually go out and negotiate and people and you can get better deals. And it can probably do it better than insurers can do it. But most of healthcare are not things that are just elective that just you want to have. It's you have to have. And once you have to have that, you as an individual negotiator, it's very, very difficult to negotiate lower prices. You're going to pay whatever they charge, okay? And the reason why you need either a government or an insurer negotiating for you for these things is they have much greater leverage to lower those costs. And so one does not it's not it's one of those things where it's another idea to put on top of our already complicated healthcare system that may help a little bit for a very small element of our healthcare cost burden. But for most of us, we who have chronic illnesses or we have to purchase drugs that we have very, very little leverage on, we need to have someone negotiate on top of us. Now, let me just say one thing about Donald Trump that is positive too, which is, you know, uh, he has thrown entities like the pharmaceutical industry or the insurance industry and say, "Hey, you need to do better. Um, uh, we need to price products more closely to international." He hasn't executed all that well, but he's put things on the table that Democrats have occasionally talked about but not executed on. He's actually begun to execute on some of these things, just not particularly well. But I think the fact that Republicans and Democrats are saying, look, our current system is not delivering. The status quo is unacceptable. Um, Harsher and more aggressive and more innovative interventions are necessary to shake things up. And that's why I'm saying I see some, and you've seen it in Indiana, price limits in Indiana, a very historical red state. So I'm seeing much more a willingness to be thoughtful and aggressive to begin to deal with pricing, the issue that Rachel was talking about. And until we do, if we're always going to be happy to pay whatever anyone's willing to charge us with no limits at all, we're going to have a hard time with our healthcare system because we can't subsidize it to affordability. And and I'm beginning to see conversations where employers are saying, "Hey, I can't pay 400% of what Medicare is paying for hospital care. I'm sorry, I can't do that any longer. Give me a break." We can't have this consolidation because I can't leverage lower prices for my employees. Give me some help. So, um, look, I want to convey it's as complicated as what we're saying sounds. It requires two things: political will to take on hard questions and a greater degree of trust in people who are proposing policy. And right now, we don't have a lot of trust because of a lot of the polarization that exists, but we do have demand for change. And we also have an upcoming presidential election in 2028, which I think is going to be framed a lot around these issues. So I'm actually, and I think Republicans and Democrats are going to force to come up with some solutions. So I'm encouraged. It's just that I'm impatient.
Want to remind you that in a little while we're going to take questions from the viewing audience. If you want to drop those questions into the Q&A bar, we'll get to them here in just a couple of minutes. Liz, is on the other side of the political spectrum, I asked you about the Trump proposal. I mean, I think we frequently hear from the other side, solutions like Medicaid for all. Is that likely to be a part of the conversation, or do you think we're sort of back to that same fundamental question as when the ACA was being put together around sort of tinkering within the system that we already have?
Good question. And I know that issue comes up frequently, particularly the greater the frustration, the more people say, can we just throw the whole thing away and start over again? And the simplest way to think about that is Medicare for all. I think that's what you meant is Medicare for all.
I'm sorry, yes, it is.
It's a system where there's more predictability, there's universal coverage, you've sort of paid in your taxes and at least for part of the program, and you have some level of a premium, but there's universality and it's run by the federal government instead of by the insurers. So can we get the middlemen out and just go more to a direct system? And I think I've actually spent a summer working for the British National Health Service. I've spent a summer working for a German sickness fund. I had a global role with a pharma company. I've seen a lot of different systems in the world. I think it's really hard to think about just taking, like, let's just take this system and transplant it here. Um, and even something as let's just grow what we have in Medicare. I think, again, it sounds like great talking points, but so hard to execute and so hard to operationalize. And I think the goal behind the proposal is a very valid goal. I just think it is so hard to think about how you move everyone out of one system and into another. I think you'd have to do it probably a long phase in time. I think you'd have to think, is Medicare really the program that we want to have for everyone? Because I'll tell you, and maybe we'll get into this, there are many aspects of Medicare that aren't working very well. And we can get into that a little bit, but I don't know that I would want to replicate that system. Um, I do believe we need to simplify the system. I do believe we need to have a system that provides a better care experience for patients. Right now, there's so much friction in the system. Watching my family go through health issues, friends experience the health system. It's not a pretty picture for anyone, and nobody's happy with the system. Doctors aren't happy because of the administrative burdens and all the. I learned a term when I was at the Innovation Center at CMS, pajama time, that doctors, after they see all their patients and they have dinner with their family and then they spend pajama time doing paperwork afterwards, late into the night. Like that, there not a lot of satisfaction in that. Patients aren't happy. Insurers, and industry feels like they're at the brunt or at the tip of the spear, getting a lot of the incoming, but feeling like they have limited tools and ability to influence what is happening. So I agree with Chris. I'm really glad that we're starting to have this conversation. I would say that let's try to avoid a simple solution that sounds like a soundbite from any perspective, whether that be from the left of Medicare for all or the right of let's just give people money. I think, our system is a lot more complicated than that. It's really easy to demonize any proposal, anything that's on the table. Even small changes become big political lightning rods of you're destroying Medicare, you're going to kick me off my insurance, millions are uninsured. So let's step back and see if we can have, more of a dialogue around what some of the real problems are and how to come up with solutions that actually would work and could be implemented.
Rachel, let me ask you, Chris mentioned, and want to hear from everybody on this, but, Chris mentioned that there are maybe some bipartisan solutions, some things that maybe we could come to some consensus on. Or what are some of those?
Thanks, Chris. Thanks for setting me up on that.
We can pass
Today
it to Chris too.
on January 30th, 2026 in Washington, D.C., it is hard to identify a particular one that's going to have salience. But I do think, we're in, Liz mentioned this, Chris mentioned this, we're in a very hyper-polarized time right now in our healthcare system, but just kind of, in our society overall. Historically, there has been a lot of bipartisan agreement and willingness to move forward and invest in things like primary care, in things like telehealth, in things like how do we explore different and better delivery models to get at both what the patients want and what the providers need and the patients need. So we're in this kind of bubble of partisanship right now, but I do think that we've got some core issues that tend to be and historically have been pretty bipartisan. I know we're going to talk a little bit about what's happening at the states. And I just have to say, like, the um, working with the states closely, working with the secretaries, working with the Medicaid directors, all of this, if you've seen one Medicaid program, you've seen one Medicaid program. And obviously those programs are governed by, the politics and the market realities and the budget realities, the fiscal budget realities. These are everyone, there's lots of people here from states and local areas. You all know that you do have to set a budget at the state level. And that's where a lot of the disconnect does come in between state and federal politics. But I think keeping track of what states are grappling with right now, and there's a tremendous amount that hasn't yet hit that we're expecting to be really disruptive in their markets. And so while we need to be thinking about long term what we can do to make the system better, there's also a lot of work that's happening right now to kind of catalog the impacts of some of these new policies, some of which haven't even gone into effect yet, really evaluating and tracking and measuring what their impacts are, because we know that policy takes a while to show up in the data, and policy windows open, and we want to make sure that we've got good data and good understanding of what some of these implications of the policy changes will be, so that when the policy windows open again, we can address those.
All right, Chris, weigh
Yeah.
in on that
Well,
way. Since I asked Rachel your
I'm trying to
question.
be a little bit look, those of us who've done healthcare for a long time have to be some combination of masochist and multidimensional chess players. Okay, that's kind of what we do. But um, I think where we make mistakes with our messaging and communication to people and our policy is we don't focus on the outcome to the two entities that people most care about. And that, to me, that's the patient and the consumer, as well as the physician and other healthcare personnel. If we focus on the outcomes for those two entities, as opposed to which structure is the best structure, focus on the outcomes that we want these entities to produce, whomever we contract out with, then and not get so drawn in onto the exact, you know, who's the structure, what's the exact structure, but you hold people accountable to the outcomes to the patient and to the ability of the healthcare personnel to serve that patient. We're going to be in so much better shape. And I feel that sometimes we do the what's up and what's down and who are the special interests and the stakeholders, who are the influencers and what the particular program is. And no one really wants to hear that too much. Um, Even this issue of Medicare for all, okay? I could have an argument with Liz about Medicare for all, about whether what is Medicare for all, right? Well, I think a lot of people think when they hear Medicare for all, they think, well, is that today's Medicare? And today's Medicare for all, half of the Medicare program is in managed care plans, private managed care plans. Are Medicare for all going to exclude them or include them? Like I'm just giving you an example of even something that sounds as simple as Medicare for all isn't as simple as you might think. And of course, if you really want to have traditional Medicare, you have to improve Medicare for all, even for the seniors that they serve. They don't have hearing, dental, vision, home care. They have no catastrophic coverage at all. Is that what you want to sell to people before you've improved the Medicare programs? You want to have Medicare for all? And what about for children? Medicare isn't designed for children. So I'm just giving you some examples, Dan, of people like us. You can't just say Medicare for all. You have to say, what is that? And what do you want to do? And when do you want to do it? And how quickly do you want to do it? And how disruptive are you willing to do? And yes, but the reason why I like to be a little bit more optimistic about this and focus on the people is we need to develop a better sense of we know what you're going through, the public. We have to say up front, it's not working. It's not working. It's too costly. It's too complicated. No one should have to go through this when they're sick. It's outrageous. And we have to say, and we have to show it that we know it because, when you say, Dan, we have all these other people who don't get all this. They don't, but there is not one person I've ever dealt with who does not have an opinion of healthcare because they've all experienced it and none of them are happy with it. And we have to, the policymakers, and particularly the politicians who we've worked for, we're peons. The policy, the elected people have to start meeting people where they are and talking to them as though they understand what they're doing, what they're experiencing. Develop the trust to be able to do hard things because there will be hard things. There will be disruptions that will be necessary in order to secure those outcomes that we're talking about. But you have to be honest about it. And you have to be honest about the timetable and you have to be honest about the expense. There's also a lot of people who aren't covered and a lot of people who are underserved that's going to cost money to actually provide the care we're talking about. So we can do a lot more in terms of being efficient and getting a better ROI, a return on our investment in healthcare, and we can lower costs, but substantially. But there's going to be some areas we're going to have to invest. And lastly, Dan, I'm just going to say, just in my positive, in the bipartisan world, rural health care, community health centers, investment in research and development. I mean, you want to talk about bipartisan? They're all a bunch of old men who are elected leaders who are afraid of dying. They're going to spend money, all this money on NIH research, notwithstanding what Doge or um, someone from OMB thinks they should cut. And they're just passing huge new increases in NIH because they know that we have to invest in R&D to be able to have the type of diagnostics and treatments and cures that we want to have in this healthcare system. So I think that's another example of a bipartisan rejection of a short-sighted policy intervention that people have been talking about. So I just want you to know there's some hope.
Good. Well, we'll take all the hope we can get. I want to definitely want to jump into the rural healthcare topic in a minute, but Rachel, I want to circle back to something that you mentioned about sort of the state experience and if you've seen one Medicaid system, you've seen one Medicaid system. Help us to understand why is there such a disparity in how states operate that program and why if you live in one state might your experience be very different than if you lived in another.
I mean, this is the question, right? Always Medicaid has been a partnership between the state government and the federal government, and always states have had the authority and ability to craft the program in a way that really meets the needs of their population. There's federal guardrails, there's federal, baselines, and then the states are allowed to kind of make policy to kind of go above and beyond. I mean, Liz talked about the Affordable Care Act. They took a lot of steps to make sure that we didn't have a gap between people who were covered by Medicaid and people who were then going to be covered by the new exchanges. Obviously, the Supreme Court, ruling that this was voluntary for states, really, kind of impacted that. And it's why we do have a lot of really interesting coverage gaps across the country right now. We've got a scorecard. The Commonwealth Fund does a scorecard of states as well as our international comparisons. And we see time and again, and this, predated the Affordable Care Act, it predates HR1, but we see time and again that coverage policy decisions made at the state level immediately impact health care outcomes for kids, for older adults, for adults, for your ability to have a provider that you can actually have access to. And so, the coverage decisions make a huge difference in terms of the healthcare experience you're going to have within your state. And so, that's the reason for the adage. If you've seen one Medicaid program, you've seen one Medicaid program. We now have a mix across the country of expansion states and non-expansion states that will impact. Expansion states will be, more impacted by HR1 in terms of rolling out some of the new policies that were in the legislation that Liz and Chris were referencing. So big changes to the way people have to demonstrate that they're working or demonstrating that they're, doing community service and how you administer that. I think what cuts across all states is the fact that we have unleashed kind of a whole barrage of new requirements and expectations on states to roll out new programs in a pretty short amount of time with fewer resources. Major cuts to Medicaid, to the Medicaid program, major changes to the way the program can be financed and how states can raise dollars. All of that impacts kind of this workforce and the morale that we've been talking about. We've got community health centers, which are kind of a pinnacle of how care is often delivered in rural health areas. They're very receptive to change in the Medicaid program or if the government shuts down. And so all of these policies play a bit of a domino effect, but there is a lot of state variation just based on the way the Medicaid program is structured and the coverage policies predominantly across the country.
Liz, I'll direct this question to you, but invite everybody to sort of jump in. I want to get to this question of rural healthcare. It's one of the places that we seem to hear a lot in the news about rural hospitals closing down and difficulties in terms of accessing a healthcare workforce in the more rural parts of our country. What is sort of underlying that problem, and what might we be able to do about it?
Well, I'll start. And I grew up in Kansas. I worked for the senator from Montana. I've seen a lot of parts of the country that really are ex experiencing a lot of the challenges of sort of a dwindling population. The population is declining or getting closed. A high portion of those in states that did ban Medicaid just
All right, Liz is breaking up a little bit. Chris, you want to
I
jump in
I
briefly?
I can speak for Liz all the time. She trusts me. Um, she's and I've worked for senators in Arkansas and Ohio and Montana as well. Um, and the same problems have existed, but actually are getting more acute as population does decline. It's very hard to recruit and retain healthcare personnel in a dwindling population base. And we have to think of very creative interventions to deal with it. One thing oh, there she is, Liz.
yes, sorry.
I was, can you hear? Can you talk?
I
Do you
can
want,
hear you.
you want to keep going? I was
If you
just filling
started,
in. I was filibustering. We both work in the Senate, so we're very good at filibustering. So, Liz, do you want to? I was validating what you were saying, so why don't you go ahead and I'll
well, I
supplement.
was saying that it's not just like there are all sorts of challenges, but I also think there's hope for creative solutions coming out of the Rural Health Transformation Program. $1 trillion of cuts in the One Big Beautiful Bill to Medicaid that's going to really put states in a very difficult spot. But Congress tried to make up for some of those cuts with 50 billion dedicated to rural health. I think it's not necessarily going to make up for the shortfall, but what we're seeing is that 50 states received funding and they've got some really innovative ideas about thinking about more virtual care, e-consults with specialists, how to develop the workforce and use physician extenders like physician assistants I think, more liberally so that they can help provide and make up for some of the gaps of the workforce shortages. How can we think about lessening the administrative burden or some of the rules that apply in cities that don't make any sense in the rural area? At the CMS Innovation Center, we hosted 3 rural hackathons in different parts of the country to try to get new ideas and new thinking. And what people said was it wasn't always just about the money. It was sometimes about the bureaucratic red tape and the provisions that made no sense in rural areas. So I think there's a lot of ways to think about the problem that isn't just about money. And I think we're at the verge of some really good ideas coming out of these rural health transformation grants that have been given to states and will be rolled out over the next 5 years.
Rachel, are there ways that telehealth and AI even have promise in terms of improving the system in the coming years?
I mean, absolutely. I think that the tech components of some of the rural health transformation grants were some of the most exciting. It was clear from the guidance from the administration that they have a lot of interest in really expanding the use of technology and maybe even AI, especially in the areas around reducing that administrative burden that we were talking about. How many times do you have to fill out the same form at the same provider's office? There are some simple things that can be done with technology. And then, more advanced, making sure that you're really supporting the patient provider interaction so that you're really saving those in-person visits with a provider for the times that you really need an in-person visit with a provider. We've seen, to Liz's point, some of the most creative approaches in rural areas that have low resources. I remember being in North Dakota looking at their telepharmacy program more than 20 years ago, where they had a pharmacy tech that was supported by technology, where they had one pharmacist that was covering the entire state. And their outcomes and their patient satisfaction kind of blew away all of the states in the region, in the area. So I totally agree that, there's a lot of potential for innovation and innovative things to come out. Telehealth and tech is a big piece of it. Because we're talking about rural, I probably don't have to remind anyone on this call, there are still wide swaths of the population in the country that doesn't have access to broadband. And so that is a major limitation when we're talking about what's possible. I mean, I think we also want to make sure that when we're coming up with new innovations, we're not widening the disparities between the haves and the have-nots, right? And so part of what we would hope that continues to be a priority is thinking through technology and innovation that's really critical and applicable for those areas where we know the health outcomes and the patient populations really need them, instead of kind of the worried well and the people with resources having access to kind of the latest and greatest technology. And so I think finding that balance and making sure that that is kind of present as we roll out policies is really important. The last thing I'll say is that AI is moving faster than any of us can even comprehend. The idea that we're going to have a policy structure or a regulatory structure that can move at the speed that the AI is going to move in is kind of is just totally mind-boggling. And so conversations have started, in our early, but I think are really important on, what are the guardrails and the pieces that we can agree on now to kind of make sure that this doesn't get away from us and that healthcare doesn't get left behind in this kind of next technological innovation.
All right, we are approaching the top of the hour. I have so many other things I want to ask you, but I want to make sure we get to some of our audience questions as well. Donna has a really important sort of practical question here. She's saying this is all great information, but also really scary for her as a small business owner. She says, "Wait, I have 5 employees who need health care. How does a small business provide health care without breaking the bank?" Anybody want to weigh in there?
Well, I mean, there actually that is has been a huge problem for years and years. And so that small businesses they get the worst deals from the insurers. Um, Oh, now increasingly what some people are looking at is having their employees go into the marketplace and then supplement their income. And that has now increased much, much more significantly than we've ever seen before. There's some other models that Republicans and Democrats are looking at to facilitate that further, so that you can utilize the benefits of the marketplace, so no medical underwriting and some access to a range of options. So most small businesses in the past, they only get one plan, they get one insurer. It's very, very costly, and they have to make very, very tough decisions. Some small business still want to offer they want to offer healthcare for themselves and or make some contributions so their employees feel like they're doing that. There's some new models that people are thinking about right now. And so I'm a little bit more optimistic because policymakers and politicians, it's interesting you should raise both of these, Dan. Rural health and small businesses, if there's been any two issues that have bipartisan interest, in healthcare in the Congress more than those two issue areas. I know not what they are. That's both to reflect the challenge, but also the opportunity here. So again, I'm encouraged, although I'm very empathetic of the frustration that your questioner asked about the limited options and costs they've had to incur up until this point.
We are winding down. Maybe I'll ask one final question and let each of the three of you weigh in on it. You know, as we look forward to the next couple of years, knowing what we know about the challenges to the system, knowing what we know about the current political climate and landscape in the country, how are you? Are you feeling optimistic or pessimistic about the next couple of years, and why?
Well, I'll start and also want to acknowledge the point in the chat that using a navigator is also a very fruitful approach for small businesses to try to find some support and ideas and um, um, approaches to making care more affordable and helping their employees. So just want to acknowledge that. I am feeling mixed, so let me tell you why I'm pessimistic. I am very worried about what's going to happen after the $1 trillion cut to Medicaid, where the Congressional Budget Office predicts that 10 million people, up to 10 million people, could lose Medicaid coverage. And then an additional, what, 4 to 5 million, looking at my colleagues, could lose coverage as a result of not restoring those enhanced tax credits and subsidies to buy marketplace or exchange coverage. That makes me nervous that we're backsliding a bit and what the solutions are going to be coming out of that. I'm optimistic because I think just going back to something Chris said, we're at a point where there is sort of maximal frustration with the system. And when there's frustration, policymakers can't help but respond to all the polling that's coming across saying, I don't like what's happening in our healthcare system, and I want to see some creative solutions. And I do think, I very much agree that the next presidential election will have to take on some of these issues. Um, and where there's a lot of frustration in the populace, I think there's room for solutions. So that's what makes me optimistic.
Rachel, how are you feeling?
I mean, I could just plus one all of Liz's both worries and also things that are giving her a little bit of hope. I mean, I think just to get even more um, kind of on the ground. We didn't talk a lot about behavioral health. One of the trends I think that's been happening over maybe the last 5 years is we're seeing more integration of behavioral health services into the mainstream kind of delivery of care, into the primary care system, more of an acknowledgement that this is one person and they may have mental health or behavioral health needs, but they also have physical needs. Why are we treating them? Trying to attempt that in several different systems. So that is also subject to a lot of the barriers that Liz was mentioning. I mean, Medicaid and Medicaid reductions are gonna impact that. But I think, big picture, this idea that you should be able to be treated holistically as a person by a care team, and if they can handle your behavioral health, they can, even if it's just to refer and refer out, and while also taking care of your physical needs. I'm encouraged that we're sort of moving that conversation forward and we're seeing that become more of a reality.
Chris, we'll give you the last word.
Well, most time you listen to people who opine about healthcare, there's an old Steve Martin joke that um, he talked, he plays the banjo, the comedian. And he
Mhm.
said, the great thing about a banjo is you can't sing a depressing song on the banjo. It's impossible. Healthcare wonks could actually sing a depressing song on a banjo. We tend to scare people off and say it's too complicated and nothing can get done. And so I'm going to be more the positive playing on the banjo, in a cheerful way to say, I think that to Liz's point, the demand for change will force people to respond. I think the use of AI to actually reduce a lot of the complexity in our healthcare system, both for physicians and payers, could actually make a real positive difference. The use of that technology for innovations in new treatments and cures are almost endless or infinite. Um, the openness to say there's got to be limits as to what we pay for this stuff, and to start having that discussion leads me to believe that you at least have the opportunity to engage. And for the people, whether you're in the private sector or the public sector, if you can actually have real solutions on cost and complexity, you're going to be fine. If you're a continued contributor to it, then your days are limited. And that's how I view it. Um, and I'm hopeful and I can't wait for it, but it will never come soon enough for me. So there you go.
Chris, thank you for helping us to end on an uplifting note. Want to thank all of you for taking time out of your busy schedules to join us. Dr. Liz Fowler is a distinguished scholar at the Bloomberg School of Health at Johns Hopkins University. Rachel Nism, Senior Vice President of Policy at the Commonwealth Fund, and Chris Jennings, founder and president of Jennings Policy Strategies. Thank all three of you. I feel like we barely scratched the surface on this complex and important conversation, but what a great hour. Thank you for spending the time, and thanks to all of you who took time out of your busy schedules to tune in today. We will be back next month and wish you a safe and warm weekend. Thank you.
Thanks, Dan.
Thanks, Dan.